and many of colleagues have seen this termed in the media as bone death. So we are going to discuss this in detail in today's program, and it's my uh, happy duty to share and introduce our moderator, Dr. KJ Reddy sir. He is the Chief Joint Replacement Surgeon at Apollo Hospital, Hyderabad, and specializes in joint replacement surgeries and complex revisions uh, replacement surgeries. He has organized many conferences and he is part of the Asia Society. He was the president of Indian Arthroplasty Association 2015-16, and he has numerous publications to his name. So welcome to you, sir, and over to you for introducing our other faculty.
Thank you very much, Ashok. That's very kind of you. And we're going to have a wonderful session. Welcome all the faculty and the delegates. We're going to have a great session. We have great speakers. I think I'll just briefly go through. Dr. Amit Agarwal is going to talk about AVN, going to introduce with the grading and investigations. Dr. Sudhir Bhabulkar is going to talk about pedicle graft and bone grafting. Dr. Gauresh Palekar is going to talk about role of autologous cultures, osteoblasts in AVN. Dr. Gautam is going to talk about role of bisphosphonates, and Dr. Subodh is going to talk about core decompression. So we will start with the first talk from Dr. Amit Agarwal from Delhi, Introduction to AVN in COVID with Grading and Investigation.
Thank you, sir. A very warm good evening to all of you. Thank you for joining in on this Saturday evening. Today we'll be discussing about the post-COVID avascular necrosis of hip joints. So why there is a special session for this? Since we have been seeing in our practice that there is a sharp rise in the post-COVID avascular necrosis of the hip joint, there must be something we are missing. So we have to find out the chain of events, what exactly is going on because of the COVID. So you'll be surprised and shocked to know that almost 30 million cases of COVID cases were there in India. And mind you, these are just the reported cases. There might be double figures which were not reported. We don't know exactly. Out of which 1.8 million cases were hospitalized and 1 million patients were administered steroids. So total patients, if you consider the patients who were given the steroids in the home setup and in the hospital, it will boils down to almost 4 lakh cases of AVN. I don't know whether this data is true, maybe inflated, maybe less. We don't know exactly. No one knows actually. But then this we can say that there is a sharp rise in our clinical practice. So unfortunately, this mostly patients are young patients in their 20 to 40 years of age group. And if not diagnosed and treated in a timely manner, they will eventually end up with hip replacement in due course of time, maybe 2 to 3 years. And most of them have 60% of them will have the bilateral hip involvement. So this shows the magnitude of the problem. That is why we are here to discuss, to create a awareness about this entity among the orthopedic surgeons. So causes, we already know there's a huge list of causes, but there is a new entrant, new kid in the board, COVID-19. Frankly speaking, we don't know actually whether the COVID-19 itself or the medications used to treat the COVID-19 is the positive factor for increase in the avascular necrosis post-COVID. So there is this talk is incomplete without mentioning this paper. So it was published a couple of months back in BMJ case report. They clearly show that 3 cases were reported which were clearly post-COVID, and they also took steroids. I will discuss about the paper in detail later on. So what exactly could be the cause? Why there is an increase in cases? It could be because the primary targets of COVID is first pneumocytes. We know the lungs are involved. The immune cells, we know that cytokine storm and all those stuff. But as an orthopedic surgeon, we are more worried about the third one, the vascular endothelial cells, which is the primary target of COVID. So what it leads to? It leads to thrombus formation. Vascular thrombosis is there all around. There is an increase in the pro-inflammatory mediators, which led to the endotheliopathy and there is a all around microvascular and macrovascular thrombotic events throughout the arterial, capillary, and venules. So it's like Kawasaki or vasculitis kind of picture. And apart from bone, there are other systemic involvements as well. Pathogenesis of steroid-induced AVN, we already know, although it's debatable, but then it's fat hypertrophy, the hypercoagulable condition, the bone marrow stem cell abnormality, the incomplete emulsification leads to the fat emboli formation, and the free fatty acid formation, which leads to the vasculitis, which in turn triggers the intravascular coagulation. So these two combined, they go hand in hand, and they accelerate the rate of AVN post-COVID. They, you can say synergistic effect in causing the AVN. So coming to the most commonly affected area, it is the anterolateral head, which is the greatest site of the greatest mechanical stress, and it directly affects the lateral epiphyseal arteries. There is an already precarious blood supply over the femoral head. We already know that anatomy, and further it leads to indirect arteries and lead to the AVN. So there is a lot of debate about the dosage. Few papers initially pre-COVID era. Now we can say that pre-COVID and post-COVID things have changed. So in orthopedics also, we used to say that minimum 2000 milligram of prednisolone or its equivalent is required. Few paper has shown that its minimum is 850 milligram. But again, you will be shocked to see that post-COVID, the people have developed AVN even after taking almost 400, as low as 400 milligram of prednisolone or equivalent. So this is very alarmingly actually. So duration, coming to the duration, usually pre-COVID, we used to say 6 months to 1 year after the exposure of the steroids. But this paper by Dr. Sanjay Agarwal, they have noticed that the average time period was almost 2 months. However, few patients landed with AVN in almost 6 weeks. So that is actually, again, too short period after AVN, after COVID. And symptoms after COVID, patients are presenting to orthopedic surgeons. We normally see patients with vague symptoms, low back pain, myalgia, all those things. Sometimes we take it lightly, but we should have a high index of suspicion wherever there is a groin pain, buttock pain relating to the knee, or knee pain. We should have high index of suspicion, thoroughly examine and do the appropriate investigations. We should not miss the bus. There are a bunch of classifications available in the literature, and according to one systematic review, the most commonly adopted classification is the Piquet and Arlett, followed by Steinberg and Arco. Michel classification is another classification used by the radiologist, and it also helps in staging the lesion severity. Diagnosis can easily be done by X-ray, but X-ray is sometimes not very useful in the early cases, but wherever in doubt, immediately go for MRI. Staging, we all know about the Piquet and Arlett. It's a gradual, according to the chronicity, increase in the severity. The idea of the staging in AVN is whether we can preserve the joint or not. Before collapse, we can preserve, yes, but after collapse, most of the time we have to salvage the joints. So stage 1, you get the bone scan, cold spot, X-ray is essentially normal, MRI, you can get the signal changes. Stage 2A, there is sclerosis and cyst. 2B is a crescent sign. 3 is loss of sphericity and collapse of the head, and 4 is severe joint space tabular changes. So this is how it get progressed. So classical stage 2 X-ray with lesions surrounded by the rim of sclerosis. Classical stage 3 AVN X-ray with a superolateral aspect. You can see the weight-bearing portion. There is a flattening and zone of decreased density, representing the crescent sign indicating the subchondral fracture. This is stage 4, obviously, irregular joint space narrowing with the osteophytes and juxtaarticular sclerosis. So there is an interesting parameter known as Kerbal angle. It is normally measured in anteroposterior and lateral view. We have to add the arc. Arc is measured from the center of the head, and if it's more than there is a systematic review published which they say that if it's more than 190 to 240, there are chances that 50% of the femoral head eventually will collapse. And if it's more than 240, it shows the severity and the poor prognostic factor. And the same thing, if you measure in MRI in a mid-coronal, mid-sagittal plane, it will be called as modified Kerbal angle. So it's a good prognostic marker. Coming to the Steinberg classification, stage 1 is normal. Stage 0 is just if a patient is having the AVN on the unilateral side, you can say the other side, stage 0, he is at high risk, but without any evidence. Stage 1 is normal radiograph with abnormal MRI. Stage 2 is again cystic and sclerotic changes. Third is crescent sign. 4 is flattening of the femoral head. Fifth is the narrowing of the joint, and 6 is eventually advanced degenerative changes. The advantage with the ARCO classification is that they have included sub-classification to add on the location, whether it's medial, central, or the lateral aspect of the joint. And there are 3 important other parameters like area of the percentage of area involvement, depending on less than 15%, 15 to 30, or more than 30. And length of the crescent is also measured. And the third parameter, which is very important, is the surface collapse and dome depression, whether this is less than 2 millimeter, more than 2 to 4 millimeter, or 4 millimeter. So it makes it more comprehensive. So there are a few classical signs on MRI. No one can miss if you see this kind of picture. On T1 weighted images, you can see the crescentic ring-like or well-defined band of low signal within the superior portion of the femoral head. It represents the reactive interface between the necrotic and the reparative zones. Whereas in T2 weightage image, you can see the double line sign. The inner hyper-intense yellow line represents the granulation tissue. You can see here it's a white T2 signal changes, whereas outer hypo-intense line shows the combination of the reactive bone sclerosis and the fibrosis. Detailed classification, although not usually followed by radiologists, but it's a very good classification. Very interesting. Stage 1 shows the early disease, and stage 2 D shows the late disease. This is how it is classified. In stage A, you can see there is a signal analog of the fat, and this is also the natural course of the disease. First, you can see the fat, followed by the blood, and third, there will be fluid or edema, and finally, you get the fibrosis. As an orthopedician, at least we know that fluid will be hyper on T2, and fat will be hyper on T1. If you know this much, this classification is done. So blood will be hyper on both T1 and T2, and fibrosis will be hypo on both 1 and 2. So these are few classical MRI pictures. As I said, that class A is early disease. It's fat-like. So T1 will be hyper, T2 will be intermediate. Blood will be hyper on both T1 as well as T2. Fluid will be hyper on T2. This is T1, hypointense. Fibrosis will be hypo on both. You can see in T1 weighted, it's a black or hypo. So what is the role of CT scan? I don't think for diagnosis, anyone uses the CT scan until MRI is contraindicated. But yes, for treatment point of view, some few surgeons they routinely do the CT scan to see the femoral head collapse, which is not clearly seen on MRI sometimes. You can clearly see the subcondylar fractures, early degenerative changes, some presence of sometimes loose bodies, or when MRI is doubtful or contraindicated. So classical axial CT scan picture will show the clumping and distortion of the central trabeculae, which represents the asterisk signs you can see here, and an adjacent low density region, which represents the reparative zone. I would like to conclude my slide by saying that early diagnosis is the key to preserve the natural joints, because most of these patients are presenting in a very early age, 3rd and 4th decade. So it's our duty that we diagnose them early and give the appropriate treatment. And I hope that we very soon get rid of this deadly virus, and we see less of the post-COVID complications. Thank you so much for the patient hearing. And I would like to thank Ortho TV and Rigro Biosciences for giving me this opportunity to speak on this important topic.
Thank you, Amit. That was a wonderful talk, detailed interaction classification.
Thank you, sir.
Now I'm going to invite Dr. Sudhir Babulkar, who doesn't need introduction. He's got vast experience in dealing AVN. He's going to talk about pedicle graft and bone grafting in AVN. Dr. Sudhir Babulkar.
Yeah, thanks, Teji. My job is made easier by earlier talk by Dr. Agrawal. Clearly, it is two things: whether COVID has increased the incidence or it is a different pathology as compared to the earlier avascular necrosis. I bring the greeting from Orange City of India, where few diseases are very common cause of osteonecrosis like sickle cell disease. In India, my area, Vidarbha, surrounding Nagpur, is the highest incidence of sickle cell patients and osteonecrosis following sickle cell disease. Now, Dr. Agrawal has made clear that diagnosis is very important. Now, in case the patient comes with symptoms similar to AVR, the only one physical finding of change in the axis deviation, restricted rotation, inflection of knee is the main clinical sign as early as 6 weeks or 8 weeks. This is a slide where you can see Suguruka, who was famous for his osteotomy, is sitting. We had a conference on osteonecrosis in Nagpur in 1992. The success of treatment is related to the stage when the treatment is initiated. All diagnostic criteria are already discussed by Agrawal. So I don't want to repeat the same thing again, which we missed earlier. Bone scan is very important. This is the cheapest investigation where you can diagnose patient at large. It has a high sensitivity, low specificity, and limited spatial resolution. This is a classical bone scan where you can see that there is a high uptake. You can see in detail the photogenic area. However, MRI has replaced all investigation since by this non-invasive method, the diagnosis of osteonecrosis can be easily suspected and concluded earliest. And this is one patient where plain X-ray did not show anything. However, we had a strong suspicion on the right side. We did MRI. MRI definitely confirmed those findings. I will not go into the details of MRI, but low intensity signal band on T1, T2 and double line sign is highly suggestive of osteonecrosis. Classification. Classification is essential. Dr. Agrawal has already given details about Fickett and Arlett, Marcus and Henneking, and Arcos classification. I follow Arcos classification, for which MRI is essential to add to the exact. Stage 2 to stage 3 are important stages, and depending upon their involvement and age of the patient, we have to decide whether the head is salvageable or not. So that is the reason Arcos classification is best to understand. Now, looking into the sequelae of COVID, it can affect multiple systems. As commonly said, lungs are the first to be affected. But however, musculoskeletal system is also affected. You have different systems which are affected. And we are learning from the past pandemic where in musculoskeletal area, there could be only myalgia, acute exacerbation of the joint pain, like arthralgia. We say many times it is reactive synovitis, osteoporosis, osteomalacia, and osteonecrosis. This is the important thing because most of the patients are young osteonecrosis who had a COVID. In my institute, 43 patients of corona were detected. 2 patients had collapse of the femoral head and were operated for total replacement by Dr. Sushruth. Now, if you diagnose early, you can prevent the collapse. Very important thing is, what is the cause of AVN here? Vasculitis, different types of vascular involvement leading to the avascularity and use of corticosteroid more than 4 to 5 weeks. Now, all those 43 patients, which there was a history of consumption of steroid in all the patients. However, those who had a collapse, they had taken for more than 6 to 8 weeks. So taking corticosteroid for a long time is one of the important cause for developing the left. Now this is a 45 years old, had a corona 5 months ago, had pain in the left hip, had severe limb, and he had pain in the right side also. Plain X-ray showed changes in the left hip. Right hip did not show anything. And we did a MRI, showed classical involvement of both the hips, more on the left with a collapse, and right hip just the beginning. He had symptoms both the sides. He had a waddling gait, severely painful gait. So left side where there was a collapse, we had to do a hip replacement. Whereas the right side, we did a multiple core for decompression on the right side. Now, if you see this particular slide, you can see that there is a advanced osteonecrosis on the left side. You can see in the axial view there is a crescent sign. But however, this particular lady, 21 years, you can't afford to do a total hip replacement. You have to decide whether the head is salvageable or not. Or in case you are doing any head preserving surgery, you have to inform in advance to the patient that this head salvage surgery may not work for a long time and might require totally as early as 2 to 3 years. So the treatment depends upon the age of the patient, whether both the hips are or single hip or rubber. Etiology of the associated disease. Now we are talking about all post-COVID, but however, some people would have additional disease in addition to COVID. Certainly, we have to give a proper answer as the need of the patient, whether squatting is permissible or not, whether he would like to do. All villagers would demand for the full range of movement where it is easy for them to do squatting position and stage of the necrosis at the time of presentation. Many times patient may not report to you for COVID. He will come and say that I had a COVID 4 6 months ago, and if you go into the detailed history, they will give you definite history that corticosteroid were given, and inadvertently many patients try to consume the same corticosteroid for more than 4 months. So I am more interested in preserving the head, salvage it. It's a biological approach. Various options are there for this core decompression with grafting, muscle pedicle, vascular, surgical dislocation technique of GAN. Now recently coming up with a stem cell therapy, and lastly, a joint replacement. We used to do osteotomies in the past many times, but with the present scenario of multiple joint replacement surgeons available, the osteotomy has taken back, and we avoid doing osteotomy since it affects the future prospects of total hip replacement. Now, core decompression, bone grafting. One core decompression and just free fibular graft is a free fibular graft. Now, this was one patient who had confirmed that this patient had a avascular necrosis. Plain X-ray did not reveal anything, but MRI definitely showed type 2 MRI. And we perform core decompression and fibular grafting mainly to protect the collapse of the femoral head. This is a biomechanical support to the head, and if you avoid the collapse, the results are good. You can see here that at 3.5 months, it is revascularized. However, fibular graft is a stud graft. It does not revascularize easily. So that is the reason we are shifted to the muscle pedicle graft using tensile fascial data. You can see this, both the hips were affected, but left was more affected. And he had no pain on the right side. Left side was painful. And we tried to revascularize the femoral head. Now, if you see that simple surgery, lateral approach, right from the iliac crest to the subtrochanteric area, You can see expose the iliac crest and then do osteotomy of the iliac crest. Take a iliac crest along with the TFL, bring it down up to the hip, open the hip anteriorly, incise the capsule. You will see the necrotic area yourself. You can confirm by image intensifier. At this stage, do a decompression of the femoral head by multiple drilling and then curating, and then TFL graft is inserted into that defect right up to the subchondral area. You can see a diagrammatic. You curate out the necrotic area and put the TFL graft along with a small piece of bone from the iliac crest. And you can definitely confirm this. You can see one side it is being inserted. It is secured in position and the hip is closed. Now this is one patient who had steroid-induced bilateral osteonecrosis. Young patient, right side was just the beginning, left side was type 3. Right side had just begun, had no symptoms, but the limb was marked on both the sides. This is 1.5 years. If you see left side is completely revascularized. Right side also is revascularized. This is after 4 years and lower down price is after 9 years. You can see his movements. Left hip is the TFL graft. See the range of movement. Right hip is the free fibular graft. Now it entirely depends upon the stage which the hips are. If one side is markedly affected, you can do a muscle pedicle or vascular pedicle, and one with the least, you can do a free fibular transplant. His gait has improved, absolutely normal gait now. This was published in the book on intake on bone grafting. This was in 2012. We had operated about 125 patients with the iliac crest graft. Now I had started doing vascular pedicle graft from the iliac crest. Now this was a patient who had pain in both the hips. Left hip was more painful. For this, preoperative angiography is essential to see whether vascular pedicle is intact or not. So this is the steps from iliac crest. Deep circumference iliac vessel is taken out with the chip of bone graft. Bring it down to the hip area, open at the intertrochanteric level, cure it out, and put this vascular pedicle. This is a very quick revascularization procedure. You can see this is a patient. MRI was positive both the sides. Right side was fairly good, left side was advanced. So we did, if you see this, there is a scar. This starts from the iliac crest, reaches up to the hip anteromedially, and then lower down to the trochanteric region. Post-operative check X-ray were done to show the vascularity in the graft. Now, if you see here, you can see that revascularization on the 3 years, both the sides. Left hip is also affected, and vascular pedicle was done. Right hip free fibular graft. This is 7 years follow-up of both vascular and free fibular. This is a right side is a free fibular. Now comparing this result, you can compare on the left side where we did a vascular pedicle graft. See the range of movement. This is 10 years follow-up. We published this article in JBJS in 2009. This 10 years, you can see that the hip is not collapsed. It is completely revascularized both sides. This is 13 years follow-up. Vascular pedicle on the left side and free fibular on the right side. This, as I said, we publish this in 2009. Recently, everything is coming up to the stem cells. Osteoblast cultured outside and then replanted inside the bone. I have no experience. I thought of doing many times, but somehow I did not adhere to it. But this is a good technique where comparatively least damaging to the hip, you can try to reverse that. Only disadvantage of this should be done before crescent sign develops, because once the crescent sign develops, collapse is inevitable. So patient should report to you at least in stage 2. Sometimes you can do in stage 3. However, it depends entirely. If the patient is around 45-50, rather than taking a chance, you can consider stage a total hip replacement. Well, not that we cannot do total hip replacement. We did almost more than 100 replacement in avascular necrosis. But the results are not that good, mainly because it's an ongoing systemic disease like corticosteroids, which are dependent. There is a defect in mineral metabolism, high level of activity in younger patients, and increased body weight. I did publish the book Monogram on Sickle Cell and contributed a chapter on osteonecrosis monogram published by American Society. I wrote a book on osteonecrosis in 2013 published by JP, where we describe everything. In my last publication research article is bilateral osteonecrosis in sickle cell disease, salvaged by early surgical treatment in single setting. Finally, it is a multifactorial heterogeneous group of disorders that leads to final common pathology of mechanical failure, and we must, with our high index of suspicion, clinical acumen, and surgical fitness, strive against this prognosis. Now the COVID has come. We should try to diagnose osteonecrosis as early as possible, and even if the patient has not reported, you should go in detailed clinical history and give the warning to the patient that anytime he develops pain around the hip or a limb or radiating pain, he should be investigated. And even if the plain X is normal, you should try to do MRI. So inference is you should detect early avascular necrosis. MRI seems to the best investigation. Core decompression with bone grafting is preferred. Only core decompression without grafting is of very limited value. TFL bone grafting is very important when both hips are affected. However, if one hip is advanced, you could do vascularized iliac grafting and other as free fibular graft. Osteotomies, which we were doing earlier, are almost not done in view of patient requiring further treatment of total hip replacement after the collapse of the femoral end. Thus, for all pre-collapse hips and some selected cases of early post-collapse, vascularized iliac bone graft is the surgery of choice, followed by TFL bone grafting procedure. So coming finally, ischemic necrotic segment. If there is no crescent sign, that means up to stage 2, you can get away by doing core decompression bone grafting. However, only core decompression, I avoid it because many times there is a possibility of collapse. When the crescent sign is there, patient is young, 30, 35, 40, you should do vascular pedicle or muscle pedicle. If the patient has stage 3, I prefer vascular pedicle for early recovery and revascularization. And in case there is collapse and secondary arthritic changes, you are left with no other thing than to do a replacement arthroplasty. Thank you. Thank you, Dr. Reddy.
Yeah, thank you. Wonderful, Dr. Babulkar. I think every time I hear a lecture, we learn a lot and so much of work and AVN. I think hats off to you, and you're still doing so much. I think that was a great talk. We will, I think, ask some questions. Anybody from the panelists have questions? Shall I start? I think sometimes, Dr. Babulkar, I've seen people fracturing the neck, trying to insert the not immediately intraoperatively, but later on insert the graft into the neck, vascular iliac graft. What precautions would you take to prevent fracture neck post-operatively?
Very important thing is you should have wide exposure, so that your point of entry should be close to the intertrochanteric line and
Right.
not the subcapital region.
Right.
If you go close to the subcapital region, head neck junction, the chances of fracture neck femur are very high. So you should take an incision, open up the neck of the femur close to the IT line.
Right. Okay.
In my experience of more than about 70 patients, I have not seen a single patient with a fracture neck femur. But however, when we are doing functional bone investigation, I'm talking 40 years ago, I had one patient of fracture neck femur.
Yeah, that shows your experience. Because I started off with in PGH Chandigarh fibular neck, but now we're doing a lot of this autologous osteoblast transplantation. And about this one, fibular graft, I quite like the fibular grafts, especially right stage. Can you just tell, would you put entire fibula? Because if it is bilateral,
I do entire fibula. I don't split and give it to two patients. The only important thing when we do this, you have to do a minimal surgery. Take a small incision at the base of the trochanter, drill completely, and then put the graft. Now, while doing this decompression, you can do multiple drills instead of only one single drill. My TFL graft works very well. I have a huge experience. Vascular pedicle takes long time. I picked up this from the Singapore. Robert Fo, who is a vascular orthopedic surgeon, I picked up from him in the year 1990, learned from him, and then I did a fellowship in Hong Kong, where KP Lung was doing this. He does for multiple things, but I could easily take up how to isolate deep circumference iliac vessel. I am happy with it. If the only one hip is affected, I prefer vascular pedicle graft. In case the hips are affected, then I do a muscle pedicle.
Right. Okay. Right.
Sir, can I ask a question, sir?
Yeah.
Sir, what is your experience in hip preservation in sickle cell disease? Because as you know, sickle cell is there can be recurrent insults because of sickling crisis. So, how has been? Have you used hip preservation techniques in sickle cell disease?
I'll tell you my data till 1996 from 77 showed that there was a high incidence of failure of total hip with a 18 to 20% of patients getting infected. So my attitude changed. But by that time, I had developed a sickle cell center in my hospital where we used to capture the patient earlier. In case there is no collapse, head preserving surgery is beautiful for this. It revascularizes and remodels very easily. But however, if the patient comes very late, when there is already collapse and arthritic changes, you are left with no other choice than to do hip replacement. Earlier, we used to do RSR valgus osteotomy for containment. However, lately, we have stopped doing that. But I still do a lot of muscle pedicle graft in sickle patients. Now, vascular pedicle I avoid because the possibility of vascular involvement again lies for lifetime for this particular patient. So I prefer to do a muscle pedicle for sickle cell patient up to the stage 3.
Thank you.
And one more question, regarding the idiopathic one, the better prognosis. But generally, we say that steroid induced will not have a good prognosis. What is your experience on that one?
Experience is both alcoholic induced and steroid induced. both have comparatively poor prognosis as compared to the idiopathic.
Idiopathic one.
Idiopathic, they do much better. And the person who are on steroid,
Yeah.
they continue to take a steroid because of the other involvement.
Right.
Corticosteroid
Yeah.
is life-saving for them. So
Yes.
the
Yeah.
results are comparatively poor. And
Yeah.
as far as possible, try to avoid or postpone total hip replacement in this steroid patient.
Sure. And there is a question and chat back. What is the size of the iliac crest graft you take? How many millimeters diameter?
It is about 1/4 centimeter long, at least about 1.5 to 2 inch.
Right.
What is more
Any more
important is
questions?
you have to preserve the vascular pedicle, deep
Right.
circumcision.
Yeah. Okay. Any more questions? I can't see anything else. So thank you very much once again. We will move on to next talk by Dr. Gauresh Palekar. He's going to talk about role of autologous cultures in avian. Dr. Gauresh Palekar, probably can share your screen and
Can you see my screen?
yes, we can see.
Yeah.
Make it big. This what is that full screen?
Okay.
Charul, can somebody? Yeah, okay.
Yeah. So it's very, thank you so much, sir. I am following one of the pioneers of hip preservation, and probably a very difficult thing. I'm really thankful to sir because he's the, like I said, the pioneer of hip preservation right now. And I feel that COVID has given us put another focus on a relatively rare disease of avascular necrosis. And like Dr. Agrawal said, that this is the bone problem that is going to be in focus because of the sheer number of cases that have been treated with steroids in India and all over the world. So the basically the disease burden of hip preservation is a post-COVID necessity. And why is it necessity? Because more than 70% of the diagnosed cases of osteonecrosis of the femoral head would require a prosthetic treatment, joint replacement within 3 to 4 years of diagnosis. This is a statistical thing. Most of these are of very young age, with around 70 to 75% being bilateral. And especially in India, where dysplastic hips are not very common, hip arthritis, the major cause of total hip replacement in India is osteonecrosis. So this is a problem which is going to emerge over the next few years. Now, I feel that I want to build a very convincing case for use of these cultured osteoblasts. And I would like to propose these following points to convince you of using or looking at it my way. First is that I would say that this disease per se is not actually avascular necrosis. The International Association for Study of Osteonecrosis has said that it should be called as a osteonecrosis because there is no vascular etiology for osteonecrosis. Though the etiology is not known, there is no particularly vascular etiology. Second thing is that I look at core decompression as a palliative surgery, as not a curative surgery, because definitely in some people it would give a good amount of pain relief, but it may not cure the disease. Third is that I want all of you to look at osteonecrosis uh, staging as well as grading in two different ways because it is very important about when you talk to the patient about the prognosis. I would also will present to you the recent scientific evidence of osteoblast versus BMAC and core decompression. And finally, I will present the results of our studies as well as other investigator studies of these cultured osteoblasts in Indian perspective. Now, first is that osteonecrosis is not avascular necrosis and it is thought to be because of a programmed cell death or or apoptosis. There are multiple studies on this, but like I said, it is thought of to be like a this is thought out to be like a apoptosis. Now, whenever you give a prognosis of any disease, like a cancer surgeon gives a prognosis, we need to know two things: what is the stage of the disease and what is the grade of the disease. For example, a cancer surgeon will talk about, whenever he's talking about a malignant tumor, he will talk about a grade of the tumor. That is, how bad is the virulence of the tumor, the mitotic activity of the disease. Also, he will talk about the stage of the disease, whether it is local, regional, or metastatic. I think we need to change our classification or the way that we think to include both these factors, stage as well as grade, before giving any prognosis of the avian of the patient that we are treating. So what do? We use two classifications, as it is they are very good. First is we stage the disease by the Ficat and Arlet classification, which has been elaborated by Dr. Agarwal. And second is that we need to grade the disease by the ARCO classification. Now, what is the difference in between the two? Staging of the disease means the stage at which we are looking at the disease, whether it is stage 1, stage 2, stage 3, or stage 4. At a rough stage, it helps to for us to make the treatment very clear. So, for example, if it's a stage 1, 2, 3 disease, then probably we can suggest a hip preservation technique. On the other hand, if it is stage 4 disease, then directly the total hip replacement can be suggested. Second important thing is grading of osteonecrosis. Now, when we grade a disease, what it means is that we are looking at the virulence of the disease. So, how do you know the virulence of the disease? How can you, if somebody with a stage 1 disease or a stage 2 disease comes to you, how can you predict that this disease is a virulent disease which is not going to get better with a co-decompression? Okay, so there are good factors which help us do it, and that is there in the ARCO classification. Though they have not named it as grading of avian, but because these are prognostic signs that we can pick up on MRI and X-ray, I think this can be considered as a grading of avian. So even if we are looking at a stage 1 or a stage 2 Ficat and Arle, but with a very high grade disease, then the fate of the head is sealed. It would require a hip replacement without intervention. So what are the things that we look at? We look at the size of involvement. I think 30% is the size. Beyond 30%, it is a very high grade disease. The involvement of the crescent, whether you are doing it on X-ray, whether you are doing it or by Kerbol's angle, whether you are doing by volume method of MRI, but the involvement, percentage involvement of the femoral head. Third is the surface collapse or dome depression. I think 2 millimeter or less surface collapse is still okay with hip preservation technique. Beyond 2 millimeter, I think the hip fate is sealed. And finally, the location of whether the medial pillar is involved, the central pillar is involved, or the lateral pillar is involved. All these, if especially the central or the lateral pillar involvement, poses a very high risk of collapse. So therefore, like I said, even if you are looking at a stage 1 Ficat and Arle, if it is a very high disease, it has got a 80% chance of progression to a femoral head collapse within 2 years, irrespective of some treatment like a co-decompression. So what are the head at risk sign where I feel that only co-decompression may not work? For example, more than 30% of the femoral head involvement of the lateral and the central pillar, Kerbal angle more than 240 degrees, more than 2 millimeter depression in the weight bearing zone, and more than 30% involvement of articular cartilage. Now, these are very logical things which you look at when you are looking at an MRI or a X-ray of a patient. And if you see these signs, then you know that this is something which is beyond co-decompression, even though the X-ray facing you at that moment is looking like a stage 1 disease. But if you see any of these signs, then this is a very high grade avian that you are facing with, and that avian has got a very high chance of collapsing within 2 years if not offered any treatment. Now, like I said, there are enough papers about core decompression, and after going through a lot of them, I feel that right now core decompression is a palliative surgery, especially it is done when there is less than 30% involvement of the femoral head, the central pillar or the medial side pillar of the femoral head is involved, and it gives excellent pain relief. But when the lateral pillar is involved, I don't think it has got any role in prognostication of the disease. Now, Huijan in 2016, he had a very large study where basically he studied all the various treatments of uh, for avian. He included everything, and the main disadvantage of core decompression he found, whether you do it with a large drill or a small drill, is only basically a 14% success rate in stage 2, and it causes lower mechanical strain, which causes early failure of the femoral head. Then the next thing that I need to talk about is cell therapy. Now, cell therapy is at an earlier stage. At this 2016, also there is not many articles published for osteoblastic therapy. So when these articles are talking about cell therapy, they are basically talking about injecting bone marrow as well as injecting BMAC, or bone marrow aspiration and concentration technique. However, these are the various studies where people have studied after injecting either of these two things, and they found that compared to the other studies, they found that the progression of femoral head to collapse stage were decreased by less than 5 times in the people injected with a cell therapy. Okay, and the chances of having a THR were nearly 50% in the cell therapy group. Now I come to why I believe that the osteoblasts are the future. Now this is a very instructive X-ray, and since I have been doing this treatment for the last 10 years plus, or nearly 10 years now, this X-ray was sent to be my patient who had undergone cell therapy somewhere in India, and he was having some doubts about the cell therapy, so he wanted my opinion, and I consulted him on online, and he sent me his X-ray for review. Now this X-ray is something I found on this X-ray which is really unique. This is basically, you can see the two places. You can see that there is a extra osseous bone formation because of spillover of the cells during the osteoblast implantation surgery. You can see it in both the hips, where some amount of cells may have spilled over into the soft tissue, and lo and behold, you have evidence that the osteoblasts work. And why do they work? Because they are the only bone forming cells in the body. There is no other cell which will form bone in the body other than osteoblasts. Now, not only are the osteoblasts bone forming cells, but they are the cell responsible for new osteogenesis. That is, they recruit other cells around them, that is osteocytes, by secretion of by cytokines to change into osteoblasts. So it's a ongoing process which happens in bone healing, and we can kickstart the similar process in avascular necrosis when these osteoblasts are placed in the right environment. So this is a very instructive X-ray for me, at least. So we come to the procedure now, which is the autologous osteoblastic implantation. As you know that our Regrow, which is an Indian company, was responsible for this pioneering effort, whereby we are able to grow the bone into a petri dish. Now what they do is basically at the first stage, they extract the bone marrow cells. These cells are then transported to the lab in a special apparatus. Then at the lab, they begin the isolation and culture of osteoblastic cells. These cultures are then, they are expanded, so they become nearly 50 million osteoblastic cells within a period of 4 to 5 weeks. And these osteoblastic cells, after undergoing quality control, they are then injected into the femoral head to give us the final treatment. So what is it that we do during this surgery? That is, the mesenchymal stem cells are harvested, converted into osteoblasts, and it is used as a cell therapy. And then the surgeon
Charles, the screen is frozen, I think. Charles, can you unmute yourself?
Yeah.
Yeah, probably can rejoin again.
Yes. I think he's lost. Yeah.
Disconnected. Yeah. Okay. That was a
Yeah,
wonderful talk.
disconnected.
So,
I'll inform.
yeah, can you just ring him? If he is not going to come back, we will
Yeah.
go ahead with the second one. Yeah. Any questions? I can't see any questions in the chat box, but I think we can have more questions while waiting. And Dr. Babulkar, is there any age restriction, age limit, upper age, where you won't do hip preservation?
More than 50.
More than 50. But now we say up to 60 is young people. We lost you.
Doctor.
I think probably
yeah. I think internet problem. Yeah.
I know.
I will just start my screen share again.
Where people, what happens if I say somebody 50, 55, 56, if I tell him that you're old, they'll get very upset.
Okay. Can you hear me?
Yeah, we can.
Yes.
Okay.
Yes.
So, second is core decompression is done with forage, and that is basically to prepare a suitable ground or a medium for laying down the cells. And finally, a gel-based delivery system is used so that there is no loss of cells, which ensures a proper adhesion to the substrate. The main advantage of this system is that we are able to inject a certain number of cells into the femoral head. Now I'm going to show you a few studies. As all of us are aware that one of the biggest names of BMAC and bone marrow was started by these two names, that is Hosier and Gangji. And surprisingly, in 2018, 2016, they came up with a paper which they compared the use of BMAC versus osteoblastic cell. They have these cells which are known as pre-op, and it is right now in a stage 2 clinical protocol, and they may be releasing it in Europe very soon, as soon as they finish the stage 2. Now, what they found was that there is, compared to a BMAC or a bone marrow implant, the osteoblastic cell has got a much better result. However, the number of these cells that they are injecting is around 18 million cells, while in India we are getting nearly 48 million cells. So they found that the people with a bone marrow implant, around 40 to 47% of the people progress to a higher stage, while they progressed around only 20% people they progressed to a higher stage when injected with osteoblastic cell implant. Now, like I said, they are using a fewer amount of osteoblastic cells, so we need to take that into consideration as well. These responders had definitely much better pain relief, and functional activity was also much better as compared to the BMAC. Now, as a part of our regulatory control, we had to, before Osgro was released to the public, we had to undergo a phase 3 clinical trial in India, where this was again a multicentric where we studied these patients in around 4 centers all across India, and we had an excellent outcome and safety with the use of osteoblast in India. This is my own paper that I published in Orthopedics in 2021, where I have, these are my earliest patients which were operated in 2010 and 2012, and now they are around 10 or 11 years post surgery. But the data that I had available was at that time around 7 years only. So I had operated on 15 patients and 24 hips. These were all early stage 2A and stage 2B patients. And within 9 months of implantation of these all the patients had resumed their normal activity, there was a significant reduction in the Harris hip score. The Harris hip score had increased, the VAS score had reduced, and the Oxford hip score was also better. They were able to walk independently. None of these patients have undergone a hip replacement, and nor has there been any progression of the hip disease. Their hip joints were preserved structurally, and the joint mechanics, strength, and function were retained at the follow-up of 7 years. Again, there was another Indian study, which was a multicentric study in a fairly large subgroup of people of around 101 hips. The average duration of this post-op was around 7.4 years. These was done in stage 2 to stage 4 hips. In spite of there being a stage 2 to stage 4, all of them had a better Harris hip score post-surgery. Around in 3 and 4 hips, around 40% of the hips had undergone total hip replacement, but these were you can be considered that as 60% did not undergo total hip replacement. But again, the instructive part was that in grade 2A and grade 2B hips, the pain relief was significant, the function improvement was significant, and they did not require any further procedure. So I feel it again that it's a very good procedure for 2A and 2B hips. Now, as with any procedure, there are contraindications to this procedure. And what are the absolute contraindications? Like I said, 3-4 osteonecrosis. Straight away, I would say total hip replacement is the only salvage. Second is there is a significant change in sphericity of the femoral head. So when you are looking at the femoral head and it does not look spherical, though there may be not any obvious collapse, but the head is not spherical, I think the THR makes more sense. In grade 2B hips, where more than 2 millimeter depression is there, again, it's a very high chance that the patient may not benefit. AVN associated with renal transplants, because these renal transplant patients, they are on cytotoxic drugs forever for the rest of their lives. If we are implanting cells in them, we do not know the fate of these cells. So that is, I feel, a contraindication. AVN with severe sickling disease. Now, two of my patients I have where there was a severe sickling disease and they have undergone bone marrow transplantation. So I feel that after that, I think it's a very valid indication for doing this procedure. And nowadays, what I've come to in COVID, you should have a look at the amount of femoral head involvement, because I've come across a few patients who are post-COVID where there is a complete femoral head necrosis. Complete femoral head necrosis is, I think, more than 90% of the femoral head is involved. It is really surprising part of the disease, but I don't know whether we should do, because there is no way in which you'll be implanting these cells into a dead zone. So again, I don't know whether it would work or not. So I feel that that would be a contraindication. Another contraindication is I want you to recognize this MRI where there is a delamination of cartilage on MRI. So this is a patient where I had, you can see that this is the MRI of the patient. This is a white line where you can make out the delamination, and during total hip replacement it was confirmed. Uh, Sorry. Second is that this is another patient post-COVID where more than 90% femoral head involvement, and it is completely, the whole femoral head is necrotic. Again, I have done a total hip replacement in this, though there is a relatively spherical head. But as you can see, with this much amount of necrosis, if I am going to inject cells inside this area, then I don't know the fate of the cells. Finally, again, a relative contraindication is AVN with femoroacetabular impingement. As you can see, there is, this patient has got a significant FAI. So even though the head remains spherical throughout for 10 years, the patient, because of FAI, will have a restricted range of motion of the head. So if the patient is willing to understand this part, then he can undergo a hip preservation procedure. Now, what are the relative contraindications? Basically, AVN on low dose steroids. For example, glomerulonephritis. I have operated on quite a few patients where the patient is on very low growth steroids, something like 2.5 milligrams of isolone, and that is being taperingly and reduced. I think it is a fairly decent way of operating. Inflammatory joint disease. So, for example, if the inflammatory joint disease is very severe, total hip replacement makes sense. But if it has not affected the joint in ankylosing spondylitis or RA, I think it, and you feel that the patient has got a fairly good amount of cartilage remaining, I think, yeah, the patient can undergo this procedure. Significant FAI, like I said, patient needs to understand that he may have a restricted movement, but of course, FAI has got nothing to do with AVN, but he needs to understand that his range of motion loss is because of FAI rather than the AVN. Uh, there are absolutely no contraindications if we are doing this procedure in patients with leukemias and lymphomas, because they are all off medication, off steroids, and are considered cured. And alcoholic AVN also, I feel it has got a relatively poorer prognosis, probably worse than steroid also. But if the patient is willing to stay off alcohol, I don't think we should deny him this procedure. The biggest advantages of this procedure is that it works very well for grade 2A and 2B hips. I feel that whenever I'm operating on a grade 2A or B hip, I can almost assure the patient of a good result if they come to me at an earlier stage. Second is that it preserves the natural movement and the function of the hips. And most importantly, it does not burn any bridges for a future total hip replacement. If whenever I have had patients who are like 6 years, 7 years post surgery, and whenever they come for follow up, I always ask them that whether they would like to undergo any other procedure right now for the hip, whether they are comfortable with the hip, and I check their Harris hip score. Surprisingly, the Harris hip score of these patients is in their very high 90s or in the late 80s, which is as good and comparable to a total hip replacement. Plus these patients can undergo all natural activities like sitting and squatting because we preserve their head. So these are a few results basically, and of excellent results of all these patients. Uh, and this with this I come to the end of my first presentation, and I'll take any questions if you have, because I will be now demonstrating uh, uh, basically the technique of this surgery.
Gauresh, I have a question.
Yeah, sir.
Now, most of the patient who comes to us, they have already established by and large grade 3, and it is by accident that we did MRI, you find that 2A or 2B is there on the opposite side. Patient straightforward only 2A and 2B rarely comes to the hospital. What is your observation?
Sir, it is. I would say that what you are saying is perfectly right. And sometimes the patient has got a grade 3 or a 4 AVN on one side
Yeah.
and a grade 2 AVN on the other side. I give them a very simple example. I say that if a husband and wife are traveling on a highway and both of them have got an accident, the husband has got a large cut and he's bleeding and is in a very bad shape, and the wife is broken a bone and she's okay relatively, she's talking also. Now if there is a layman on the road who's going to choose which patient to send to the by ambulance, the layman is going to choose the husband because he's bleeding. But if there is a doctor, he's going to choose the wife because the husband has got no chance of survival. So if the intelligent patients, they are able to get the message across, and they would get operated for a grade 2 hip with me, and hopefully I'm able to convince them for a total hip replacement on the other side.
How many
That's
patients?
a good way of triaging.
Yeah, sir.
Like, I think wonderful talk. I think your logic, I liked your logic, but that's what I believe. And sometimes we do extend our indications, which is not appropriate. And those are the patients who are not happy. If you extend to grade 3, maybe the change collapse of the head, I think they won't be happy. We know that they're not going to benefit, and no point in trying. I think my logic also, most of the people come with bilateral, majority come bilateral, and one side is advanced, as Dr. Babulka said. The other side we can save. So what I would do, I would do the cell therapy first, osteoblast first, then go for replacement, as you rightly said.
Gaurav, one more question. How many patient of yours where you did a totally replacement on one side and treated by your osteoblast on the other side?
Sir, I would say around I must have operated on one side osteoblast and to other side totally replacement around 25 plus patients. And whenever they come for follow-up, I always make a point of comparing their Harris hip score. They are invariably, sir, they are more happy on the
With the
natural
cell
side.
therapy.
Yeah, the reason is very simple. Because they say that they have to be more careful in their mind with the artificial hip, while on the non-artificial or the normal hip, they feel that they can do anything. So I think that is the difference. And when you check the Harris hip score, sir, surprisingly, like I said, excellently done total hip replacement. I'm saying an excellent. So a perfectly done total hip replacement will have a Harris hip score of 90, 85 to 90, sir, because they cannot squat, they cannot tie their laces.
Yeah.
Some of them have to use the railing while climbing up the stairs. So it is very instructive. So when we are comparing a Harris hip score of a biologically preserved hip versus a total hip replacement, it is an identical thing. The only thing that I am now looking forward to is how these patients behave, say, 10 years from now. Whether the preserved hip remains preserved for 10 years, 20 years, that is the very instructive thing it will be.
Okay.
Yeah, I think that's a great talk. I think we are overrunning the time now. It's a 9:12. We're supposed to complete at 9:30. So you can quickly run over your video. That would be nice.
Yeah, I'll just run fast on that. Yeah.
We got two more lectures to come.
So I'll just start very shortly that this I started in around 2008, and first patient was a 19-year-old doctor, a grade 2B lesion with a very large subchondral collapse facing a total hip replacement. In this patient, I use a trapdoor technique, Rosenwerter's trapdoor technique, where I curated out the dead bone. The subchondral fracture was elevated by a TAMP, and calcium sulfate, tricalcium phosphate was used in the subchondral region to support the bone. And for bone growth, I used Osgrowth. They were just introducing their product in 2008. So this is the first X-ray. 2 millimeter more collapse, massive involvement of the head, and basically fated for a total hip replacement at 19 years of age. The immediate post-op X-ray, I was able to elevate the cartilage, and you can see the calcium sulfate cement inside. And this calcium cement was the one which I felt would support the head till the time that the osteoblast can grow and support the head. This is the 15-month post-op X-ray, which is very instructive because it shows that the calcium sulfate and the tricalcium sulfate has resorbed, which is suggestive of a vascularity in that area. So I knew that their head is now completely vascular, and there is a joint space maintained, joint contour maintained, and you had a fairly decent pain relief also at that stage. Now, the patient failed at around 2 years, and he went ahead and got a total hip replacement. Uh, Instructive thing was that I need to make a correct choice of case. So 2A, 2B is the perfect place to do this surgery. Second thing is that it underscored the point that the restoration of vascularity is possible by cultured osteoblasts. Third is that curettage of the dead bone is necessary, and the joint motions, space, and mobility were all maintained till the eventual collapse. Now, surprisingly, this doctor at 19, I did a co-decompression by multiple drills on the opposite side, where he had a grade 2A lesion, and that collapsed at around 1 year. So the cultured osteoblast site lasted more for him. Uh, so I also decided that we required a different approach to the hip rather than anterior approach, because anterior approach was very messy and a very large incision had to be taken. So what are the current principles of implantation surgery? The correct, of course, the first thing is the choice of the case, 2A, 2B or less than 2 millimeter depression of the cartilage. Second is the lateral approach to the hip. I've used because it's a very common approach used by us. All of us are very familiar with it, and it's a very less traumatic approach. Third is that co-decompression has to happen into the dead zone of the femur. You need to place your drill very, very perfectly into the dead zone. I use a 8 millimeter drill to access and to remove the dead bone. I curate out as much as dead bone as possible to create space for the osteoblastic cell and to decrease the quantum of the dead bone inside. I am very, very careful about injecting the cells to prevent the spillover. I restrict the weight bearing for nearly around 2 months post surgery, and I concentrate post operatively in maintaining the range of motion of the hip. As soon as the patient is post operatively, he starts exercises very rigorously the same day of the surgery. So first step is basically positioning an X-ray. I'm just going to run over this because the video is there, which is going to happen. Second thing is that whenever I'm putting the guide wire into the, I make sure that it is in the center of the avascular zone, and there is at least a 10 millimeter space from the tip of the guide wire to the center of the head, at least 1 centimeter difference, and from the superior neck to the center of the guide wire. So basically, when you are using a 8 millimeter reamer, what happens is that, okay, with the 8 millimeter reamer, it will take out 4 millimeter bone. So still around 6 bone remains to prevent a pathological fracture in this area. Also, you will see that my entry point here is not very inferior to get into the superior lateral area. It is almost at the crest or just below the crest, because this allows me to do early weight bearing. And I've never had a fracture or a pathological fracture in so many cases that I've done. After gaining access to the disease area, what I do is basically then ream it out. This is reamed out, and after reaming the head, you can see, always you see the reamer, that there is a dead bone on the present on the reamer, and this is the dead bone which you can see on the reamer. I'm very, very slow while reaming to prevent thermal injury. So you can see the differentiation between dead bone and live bone onto the reamer, and the amount of bone that I'm curating out. Okay, there is a large amount of dead bone which actually comes out. Like I said, Rosenwasser is basically introduced the term light bulb, and he started curating the femoral head. And I have basically convinced that it is the one which helps to maintain and get a good result eventually. The curating of the sequestrum is very important, and I do it with multiple angle scoop which I have available to me. This is the curating, and sometimes when you see a bony ridge which is very hard, bony ridge, and in that case what I do is I will have to drill again and again that bony ridge till the time that I am able to make a fairly large cavity inside the femoral head to allow the cells to go inside. Otherwise, there will be, if there is inadequate cavity inside the femoral head, then what we are talking about, there will be a large spillover of the cells, and the patient may not benefit as much. The injection is by the inside out technique. And here you can see that there is a plug that I've used to prevent the spillover. I also turn the patient on the other side to prevent spillover. There is very rarely a spillover when I use this technique. So this is Dr. Charulat specifically asked me to do a video demonstration of this thing. And basically now the patient is taken on a fracture table. Make sure that you are going to get a very good AP and a lateral of the hip. Lot of time these patients have got abnormal neck and shaft angles. Like here you can see that there is a retroverted head relatively, so that makes the point a little bit difficult to go into the head. uh, you approximately find out the area of where you are going to enter from in the AP as well as lateral, and this is the area of necrosis of the femoral head in this case. So you have to be very clear about your entry point. Should not be very down here, because that will you'll have to prevent or restrict the weight bearing for a significant amount of time. Now this is where I'm marking the femoral, the various surface marking, that the dip of the trochanter. You can see the superior part of the trochanter. Now I'm feeling the anterior border of the femur there. The posterior border of the femur is felt. Uh, and thankfully this is a very thin patient, so this makes it very easy. Now that is where the crest would be. So I've marked the crest also. Okay, so I know where I'm going to take the incision, approximately slightly above and below this line. And right, depending on where I'm going to put the needle or the guide wire, I'm going to mark the incision accordingly. This is the incision. It's like any standard approach, to lateral approach to the hip. And after going through it, I basically isolate the gluteal bursa, make sure that I incise it and suture it back again, because it prevents, post the scar tenderness. It is supposed to prevent. It is a technique that I have used from total hip replacement. So even in a total hip replacement, I would suture the gluteal bursa back again into its proper place to prevent scar tenderness. So that is the dissection of the gluteal bursa. You preserve it by cutting it at the back and reflecting it above. And then finally identification of the ridge. The Basically you do not need to elevate the vastus lateralis very much. At the area I would just take a vertical incision at the ridge and then reflect the vastus lateralis little bit inferiorly to get access to the femoral head, to the lateral part of the shaft. Now this guide wire has been passed and it is right in the center, as you can see from the it is at least 1 centimeter from the neck, so as to prevent any chances of iatrogenic fracture. In the lateral and AP you can see. Now second stage is the drilling. Drilling very slowly, so as to not cause thermal necrosis. And yeah, you will sometimes feel that when your drill is entering into the avascular zone, you will have a feeling that you have to give an increased pressure on the head, on the drill, so whenever you are entering the avascular zone. And a lot of times you find when you enter the avascular zone that there is a very special kind of uh, liquid or a fat with globules of fat, or some sand like material of dead bone which usually comes out. This is a special toothed curette which I'm using to loosen up the bone in the avascular area so that I can take it out with the other curettes. And I have started now scooping this thing and gradually taking out bone. Here I have used it again in case when I find that there is a ridge of bone which is preventing my access into the femoral head. I will do it in again and again. And here this drilling is happening at the lower end of the cyst, at the area where there is a vascular and avascular zone, so as to increase uh, the area where the revascularization can happen from. Now this is where how the curette, you can see the amount the curette is able to move inside, indicative of the amount of bone that I have curated inside. And surprisingly, you can see I can reach through this curette with a very small curette. I can reach the anterolateral zone also, less than 1 centimeter. Now this is I have access to Tata bone basically, and I create a bone plug out of Tata bone. Okay, with the bone plug, I feel that I am able to do a fairly good uh, spillover. I can prevent that. You can also use bone wax and remove it later. Then I will use a 1.1 mm or 1.5 mm K wire in the direction of wherever this thing is, my needle is going to go. The direction is important because here there is, in the bone plug, there is only a single hole there. So the direction of the K wire is very important. I am now checking that the needle is able to pass through the bone plug. Very easily it is passing, and this allows me to prevent any spillover of cells. Now I am injecting, this is where I am now injecting the bone plug, or I think I have already put in the bone plug now, and I am putting the needle inside now. Yeah, the needle is put inside. You check on the C-arm, you can see the bone plug there. You check on the C-arm whether the needle is gone into the area where you want, and then you tilt the patient on the other side. Yeah, the patient will be tilted as much as, since the patient is on a fracture table, there is no risk of a fall or anything like that. And now we are injecting the cells. Two sets of cells are injected. Yeah. So I think that concludes the technique for the surgery, basically.
Thank you very much. That was a wonderful demonstration of video.
Thank you.
Yeah, can't see any questions. So shall we go ahead with the next talk by Dr. Gautam Pedicle? He's going to talk about role of bisphosphonates in avian, medical treatment protocols in avian.
Yeah. Can you hear me?
Yes, we can hear you.
Yes. Yes.
Okay.
Yes.
Good evening, everybody, and nice to meet all of you. Some of you have been in touch with on our WhatsApp group, but I haven't really met you personally. So it's nice meeting you. This is a group of surgeons. So I may not be very popular tonight since I'm talking about medical management of AVN, but I think there is a role where at least we can think of using bisphosphonates. There have been many papers to support the use of bisphosphonates. I use it as an adjunct. I have a caveat for today's talk because I also do osteoblast implantation. So I use bisphosphonates as an adjunct to my treatment. But there have been several papers where bisphosphonates and various other medical pharmaceuticals have been used to treat avian exclusively with pharmaceutical agents. So just quickly coming to the pathophysiology of AVN, there's an altered intramedullary blood supply, and basically there is some embolic phenomena, especially now with COVID. I think thanks to, in COVID, basically there is an embolic phenomena, which I think is one of the reasons which is contributing to the increased number of AVN seen in COVID, along with, of course, the steroid use, which is being used in COVID. And as was mentioned by some of the earlier speakers, the surprising thing about COVID is that we are seeing avian appearing very fast and very rapidly within a few weeks or within a few months of the COVID episode, patients reporting avascular necrosis. So the other pathophysiology is there is an increased osteoclastic activity, there is an increased osteoblast death, and there is a replacement with fat cells. Sometimes there is thinning of trabeculae, and this thinning of trabeculae leads to subchondral fractures, and this subchondral fractures then leads to finally collapse, change in the sphericity of the head, and then subsequently secondary arthritis, which is the end stage where you need total hip replacement. So the aim of medical management is basically to address some of these factors which contribute to osteonecrosis or avascular necrosis. One is to address the embolism, then to reduce the fat deposition, improve the blood supply, and increase the bone strength, especially trabecular strength. So pharmacotherapeutic approach to avian would be to use, these are the various things that have been used, blood thinners. I also use Ecosprin. Some people use blood thinners like Xarelto, statins. Many people have tried using statins, prostacyclin. Recently, somebody was talking about using calcitonin and also using teriparatide. And there was I had watched one webinar where one speaker spoke of using methotrexate because he felt that osteonecrosis was secondary to an inflammatory process. But I shall speak more on bisphosphonates because bisphosphonates have been used for a long time and have been become almost the mainstay of pharmaceutical treatment in osteonecrosis. So the mechanism of action of bisphosphonates is to inhibit bone absorption, inhibit development of osteoclasts, induce osteoclast apoptosis, reduction of osteoclast activity, stimulation of production of osteoclast inhibition factor, and the newer bisphosphonates also inhibit cholesterol synthesis, which could lead to less fat deposition there, and also possibly improve the embolic phenomena. The rationale of using bisphosphonates is to increase the trabecular strength, prevent collapse by increasing the trabecular strength, promote revascularization, and avoid joint replacement. The advantages of using bisphosphonates and medical treatment is non-surgical approach, a fair to good results in early stages, and maybe a good first-line management in post-COVID AVN. The first reported use of bisphosphonates, as far as I could find in the literature, was reported by Dr. Sanjay Agarwala in 2001. And then he has reported subsequent follow-up studies again and again with 3-year follow-up, 5-year follow-up. And I think recently he had a 10-year follow-up. There were also some multicentric review articles which had 5 randomized controlled trials of the use of bisphosphonates, where there was somewhat conflicting reports, but the general consensus was that bisphosphonates are useful and are, as compared to placebo, they found that it was useful and was able to prevent further progress of osteonecrosis. The present protocol, which I have been using is alendronate 70 milligrams per week for 3 years and zoledronic acid infusion annually for 3 years. Though actually I have not yet had any patients where I have completed the 3 years, but there are some of them who have completed around 2 years. Sanjay Agarwala was the one, I am quoting his report because he is the one who seems to have done the maximum number of work, maximum amount of work on the use of bisphosphonates, and has also reported repeatedly on the use of bisphosphonates in the treatment of osteonecrosis. So he, in his latest report, had no surgical intervention in 92% of cases, an overall collapse rate of 28.8% in stage 1, 55.8% in stage 2, and radiological progression was seen in 46% stage 1, 54% in stage 2, and 20% in stage 3. The conclusion from all this would be that bisphosphonates are an important adjuvant to the management of AVN, but not a complete solution. I would not think that bisphosphonates can completely replace surgical alternatives to the management of osteonecrosis. Thank you very much.
Thank you very much. I think that made it very simple and crisp and clear, especially when everyone is falling asleep. Wonderful talk, wonderful talk. Any questions for this one? And could you just tell us what would be the appropriate dose, roughly?
See, the dose which I use basically alendronate.
Yeah.
So I am using 70 milligrams per week.
Week? How long?
I use, so far, all my patients have been using it for about, see, in the early years, I've been doing osteoblast implantation for a fair amount of time, though not as much as Gauresh, but I've also been doing it for possibly about 4 or 5 years now. And in the early years, I was using alendronate only for 3 months.
Right.
Then I read some papers by Sanjay Agarwala, and he was recommending much more extended use. So I increased it to 1 year. And now I've been using 70 milligrams once a week I'm planning to use for 3 years as recommended by him. But he also uses zoledronic acid annually, 1 injection of 5 milligrams annually. I have used so far only in 2 or 3 patients. I feel that using alendronate 70 milligrams is much more easy, more compliance, and it's easy for me to follow what the patient is doing, because I mean, the same problem might be there with Gauresh. I get a lot of patients from outside Bangalore, and it's not easy for me to organize every time the zoledronic acid infusion.
Yeah. If you kindly share your screen while we're discussing.
Okay.
Can I?
Dr. Subodh can share his screen. Any more questions?
Yeah, sir, one question.
Yeah, go on.
What is your, sir, medical management after cultured osteoblast implantation? Any specific do's and don'ts as far as medical management is concerned? Both to Dr. Gores as well. Question.
What exactly do you mean by medical management? I just said that even after the osteoblast, I give bisphosphonates, I give alendronate 70 milligrams once a week. And so far, I've had some patients whom I've given up to about 1.5 years, almost 2 years now. But
Dr. Gauresh? Yeah.
Yeah. So what I have done is that I've got an ongoing study where I've differentiated 2 groups of patients where I've given teriparatide for nearly a year. Especially these are the patients where there is a very high risk of collapse because of the obvious reason that we know by theory at least that teriparatide is got a positive influence on the osteoblastic cells. So that's the reason basically, but I'm yet to find any significant difference of use of teriparatide. I give them calcium, vitamin D, nothing unusual.
Other. And how long would you like to continue?
See, teriparatide for osteoporosis is recommended safely up to 2 years. Yeah. Then one more thing is that L-arginine, if granules are
Yeah.
used in medical management of avian also. There are a lot of papers on use of that. I use that also because once in a week, sachet of 3 grams
Right.
for around 3 months or so. Basically, L-arginine is used as a basically required for formation of nitric oxide, which is a major vasodilator, um, and which is responsible for vasodilator in the smooth muscle vasodilator. So that is also what I've used in medical management for some time back, but now I don't use it anymore.
What about
Yeah.
ecosprin and
Yeah,
Teclis?
I use EcoSprin also. I've been using now recently. I've been using EcoSprin.
Yeah. I do use about 18 months to 2 years post-operatively for osteoblast treatment. Dr. Babulkar, what is your opinion on using bisphosphonates in avian?
All my operated patients, I give them alendronate and continue.
Yeah. For how long?
1 year.
1 year. Okay. So we all agree that we believe in bisphosphonates. So going on to the next talk, Dr. Subodh Mehta, the last talk of the session, is going to talk core decompression. The good, bad, and ugly. If you could kindly share the screen and yeah, go on.
How do you? Can you see the screen?
Yeah, we can.
Okay.
We can. Yes, sir.
After being the last speaker, I hope I can add some valuable points because all my esteemed speakers have covered most of the important points and salient features of osteoporosis necrosis. So it's basically surgical breathing, as we have seen in Gauresh's talk and excellent video demonstration. But literature shows that clinical outcome of primary THR in young patients has not improved over the last few years. The mean Harris-Hipp score for this group remains at 84.6. So still there's a role for hip for the core decompression in younger patients, and especially stage 1 and stage 2. So we have gone through this literature, but just one interesting study I came across was that there was a clinical study where there was a reduction of AVN when the statin was given with the steroid. So since we are seeing the surge of COVID AVN, we should think of adding the statin in all those patients. Very important tool which we got since last few decades is MRI. It is definitely much superior than X-ray. X-ray is we miss the early AVNs. So we get early diagnosis, allow determination and exact stage. It's very good in staging and extent of the pathological process. It's non-invasive, and also it can be done repeatedly to follow the progress of the disease or resolution of the disease. One important thing which is I wanted to mention was there's another entity called transient osteoporosis of hip. Since with COVID we are getting very rapid AVN, we should not confuse it with the transient osteoporosis of the hip. The MRI definitely is an important tool to distinguish this. And clinically also the transient osteoporosis has got very stormy onset, unlike the AVN. So this clinical condition we should remember because it is self-limiting with calcium, rest, and non-weight bearing. And when in doubt, we should do MRI and always postpone the core decompression if we are very convinced that it is a transient osteoporosis, because it is a self-limiting clinical condition. So as we all know, FICAT developed a staging system in 1960s, and this all we have gone through. So since my topic is core decompression, basically even this technique was developed by FICAT and Arlett. It is postulated to be effective because it was believed that it removes the necrotic bone and gives the channels to improve the blood supply. So this is the concept that it decreases the intramedullary pressure of the core and it has shown that the short-term effect of increased femoral head flow due to core decompression in the rabbit model. Core decompression is expected to relieve pain and to allow creeping substitution to the necrotic area by bringing the blood supply. This is the effect of core decompression on femoral head flow in a steroid influence induced avascular necrosis in femoral head. The femoral blood flow this was an animal study, of course, though it showed that there was a gradual normalization within 4 weeks after core decompression. So the animal study showed that the steroid-induced AVN got good revascularization after the core decompression because of the creeping substitution and decrease in the pressure, intraosseous pressure. So what is the preoperative? Basically, obviously, we'll as per the indications, we'll not do it for stage 3 or stage 4. We'll always do it for stage 1 or stage 2 patients and younger patients. Of course, as Dr. Babulkar has said, after 50, we do not really think about hip preservation in AVN because they are likely to be progressive. But even in some patients of stage 3 who are very, very young, it can be a good time-buying tool to postpone the hip replacement, though we know that is going to be inevitable. But so patients like 19 and 24-year-old, I will still be using especially core decompression with some adjuvant therapy. So now with adjuvant therapy, the indication is getting extended, especially when the patient is younger. I decrease the bar for the core decompression because a lot of good adjuvant therapies are available. So as we have mentioned, it's quite often it's bilateral and we should not miss that. We all have discussed this curval angle, and to calculate, how do we calculate is basically AP and lateral X-ray, and also on MRI we can calculate, it's called modified curval angle. So we need not have, sometimes the lateral X-ray is a restricted hip range of movement is a problem. So we can still calculate by using the MRI. It's called modified curval angle. So we can determine the degree of AVN involvement by using the sagittal and coronal section, mid-sagittal and mid-coronal section, and still calculate a curval angle when the lateral X-ray is not possible. So as we have mentioned, the small is 160 degree or less, it's favorable for getting good results. Medium is 161 degrees to 120, and large is more than 200 degrees. Definitely it's a deterrent for doing a core decompression. So this is one of my patients. She was 54-year-old, and obviously this is not a core decompression. We have done a THR, and just for clinical interest, you can see that there's a defect in the bone. There's a decompression. The bone is collapsed. So we cut open in cross section, and you can see that whole of the head is involved. And you can see the boundary of necrotic and normal viable bone. And also I tried to draw curval angle there, which is very large, even in one X-ray. So AP and lateral, you can see the curval angle will be definitely more than 200. So we took a good call and did a THR. This is what we did for this patient. So what is the technique for standard? Basically, as Dr. Gaurish has nicely video demonstrated, we need not go into the details of the technique, but only one thing I wanted to bring into the notice, for especially for younger orthopedic surgeon, that we should take the entry point inferior to the lesser trochanter, because inferior to lesser trochanter, as I have shown in the first X-ray on left side, can definitely cause a fracture, stress fracture during mobilization. So you try to always take the entry point superior to the lesser trochanter and try to keep the safe bone from anterior and posterior margin, and try to be in a disease area, that is try to be more anterior and more superior by keeping the proper margin for safety to avoid the pathological fracture. So this is single core, 8 millimeter core we do. Also multiple drilling technique is equally effective as per the literature. So when I went to the literature, it shows that the favorable results have been only in stage 1. You can see that survivorship was 94% for the patient who had stage 1 disease and 82% for patients who had stage 2 disease. Fairbank also reported in an 11-year mean follow-up. The total was, it was from 8 to 18 years, but the mean follow-up was 11 years. Again, the survivorship was 88% for stage 1, 72% for stage 2, and 26% for stage 3 of Ficat-Arlet. So all these, most of the studies which I went through when I was going through the literature, that they have been always the outcome was better in the stage 1. Also, it also depends, as say, they noted that larger size lesion had significant greater chance of clinical failure. So the size of the lesion also matters, and the Ficat-Arlet stage also matters, the collapse also matters. So they concluded that candidate is in a pre-collapse stasis with lesion less than 15% of size is an ideal candidate for a core decompression. Another paper which shows that core decompression or traumatic osteonecrosis, it showed that staging with the FICAT class demonstrated most statistically significant correlation. So they found that the FICAT classification staging was more important than the size of the lesion. So out of the two parameters or indications, that depression of the femoral head is more important indication. If it is stage 2 or stage 3, we should not be doing. Size is secondary important. Another paper which suggests that it was a 1986 paper. So they found that there were 4 patients developed postoperative fracture. So I'm purposely saying it's a 1986 paper. So as we go through the literature, we'll see that the papers after 92 and papers before 92, there has been a vast difference in the result. So probably surgical skills have improved, surgical techniques have improved, and because of adjuvant therapy. But here you can see that this has been negative result with the core compression. So in fact, they concluded that core decompression should be considered a relatively ineffective procedure. This was a report in 1986 and with significant morbidity. So there have been contradictory report because this is how it's evolved. So efficacy of core decompression as a treatment for osteonecrosis of the hip. It's again a systematic review. It shows that after minimum 2 years of follow-up, you can see that people who had lesion less than 50% bone involved have good surgical score. That is Harris score of 70 plus. So it was again noted that core decompression is best when performed in the early stage of the disease. So even in few cases where it was performed when there was more than 15%, up to 50% bone involved, there was a good follow-up, good Harris score. So overall outcome of traditional hip decompression, core decompression, as I said, the older papers have been showing a poorer result, and the recent studies have been showing better result. This may be due to improved patient selection, also because of the use of MRI before choosing the patient. So probably we are diagnosing it early and we are not missing the boat, as they say. We are diagnosing in a pre-collapse stage where the X-rays are normal. So here also one more study. Again, it also suggests the same thing that a lot of people done before 1990s required more of hip replacement. Similar result. Now, as we are saying, there are different techniques available, better imaging is available. Also, there are newer technologies available. It's a newer technique which is there now. It's called modification of advanced core compression. It gives a expanding reamer. It is called percutaneous expandable reamers are available. So you can core more necrotic bone, but also unfortunately, because it's not only 8 mm, it goes and forms a big area inside. You have to actually bone graft it. So this technique is supplemented with the autologous bone graft and also bone marrow aspirate. So this is showing very good and promising results. Because of this expandable reamer, you can use a smaller incision and use the autologous bone graft with the bone marrow. So this is one of the newer technique which is available now. Though personally, I have not used this yet, but this sounds promising. So as I've been saying, that adjuvant therapies and procedures are helping. So I am no more doing a core decompression alone for last 10 to 15 years. In fact, I started with the fibula graft, strut fibula graft. Then I started with bone marrow aspirate concentrate. And now I'm using this Osgro. And I'm finding very good results with Osgro. And what I'm finding in my clinical practice is that we are seeing more and more younger people with AVN. Some of the profile is changing to younger and younger people. As Dr. Gaurisha said in his showed that one of his first patient was 19-year-old patient, doctor, medical student. So also the patient which I operated today was only 22-year-old. Today morning only we did one Oscro. So adjuvant therapies like bone grafting, addition of mesenchymal cells, tantalum rod insertion, but this has failed because there was removal is a problem, and somehow they got a lot of fracture report also. So now the procedure more scientifically applicable, I feel, is bone cell culture, because we get huge number of bone cells, osteoblasts, like in the tune of 50 million. So this is like patient which we did today morning itself. He had actually 20. He's a 21-year or 22-year or 21-year. He's a 21-year-old young student, and you can see the disease is involving almost most of the femoral bone area, femoral head, and this is actually almost level it's like a 3, type 3. But because he's 21, we did a lot of counseling, and even patients nowadays come are Google knowledge. They come with the Google, they're Google doctors. So even they come and read everything and they know about hip preservation. So as a doctor, I counseled him a lot that this is likely to fail. But since in lateral X-ray, I felt that the sphericity was good, we decided to give it a chance. And as I was said, I want to mention and insist, and you have to do a lot of counseling for such patients, because you have to, especially younger people, I tell them this is like a night watchman. This may work for a few years. Sometimes a night watchman can hit a century. But especially patient comes in stage 3 and expect his one of your old patients referred, it may not be that successful. A lot of counseling is required. Otherwise, there can be medical legal implications also. So this is the exercise of that patient. This is what we did. You can see that necrotic zone is very large, and we did Osgrowth today. So take-home message I want to give is that you have to have a high index of suspicion in a clinical practice. Moment you suspect, don't delay the MRI. MRI to be asked as early, if no relief if the patient comes with a groin pain and is not getting relief in a week or 2, it's very prudent to ask for MRI. As most patients are young, must try for adjuvant therapy with core decompression, along with the core decompression, to give the best shot to that patient. You can't just do a core decompression and say, my hands, it is good. You have to use some kind of adjuvant therapy to augment the result of core decompression. And as I again repeatedly been saying, good counseling pre-op, as procedure has limitations and patients often present late in our country. Thank you.
Thank you very much, Dr. Mehta. That was a wonderful talk. And can I ask all the panelists, see, whatever treatment we are giving, good results are in stage 1 and 2, and the results are bad in 3 and 4. Do you think the natural course of the disease is like that? Whether we treat or not, stage 1, 2 will be better without even treatment? Is there any randomized clinical study anybody can quote?
Earlier studies.
Dr. Gauri, yeah, go on.
Earlier studies made it very clear that about 10 to 20% of stage 1 might go without treatment. This is around 88, 90. JP Jones had published this article. Subodh, I have one question to you.
Yes, sir.
That only core decompression relieves the pain, but does not help anyway for revascularization.
Yes.
That is the reason only core decompression should always be associated with some sort of grafting.
Yes. Yeah, I think that was a wonderful session. I think we all believe that core decompression alone doesn't work. I think the good message, take-home message, it has to be supplemented with the bone grafting or any form of cultured cells, which will support, taking out all the dead bone and preventing further collapse, and probably it might repair. Any more questions? Any more comments?
I think one thing that we have to look at when we are looking at AVN is that we have to look at the condition of the cartilage, because with excellent amount of good amount of 3 Tesla MRI available right now, I think we should be pushing our radiologists to better imagine their cartilage. So because it will help us make a better decision about hip preservation. So if we are able to cartilage imagine better, and I think like I showed you that it is possible to identify delamination of cartilage or unhealthy cartilage on MRI. So I feel that all of us here are doing Osgrow, and it is very important for us that we choose the right cases, so that this is I feel after such a long experience that it's a very viable way of treating avascular necrosis, which I feel is in the next probably decade, it is going to be a major problem, health problem or at least orthopedic problem world over. So
Absolutely.
this is what I feel.
Yeah.
Gaurish,
I think in the knee we do cartilage mapping. You're absolutely right, because we just treating, there's no point in just treating a dead bone when cartilage is already damaged.
Correct.
And we should have a viable cartilage when we are going to restore the dead bone. Your point is well taken.
Gaurish, assessing the cartilage by MRI is not that easy. But however, when you see a crescent sign, it shows that there is a definite cleavage between the cartilage and the bone. So as far as possible, any head preserving surgeries may not be very effective when the crescent sign is seen.
But the crescent sign is within the bone, is not underneath the cartilage.
Within the bone, yeah.
Doctor.
Yes, it is in the
Sudhir?
bone. It is in the bone, subchondral bone.
Yeah, but that is, you think that is indicative that there is a
Yeah.
delamination of the cartilage.
Yes.
Okay. Charul, final comments?
Yes. I am thankful to all the speakers, and it was with the short notice, everyone has joined and gave the valuable knowledge to everyone. Thankful to Dr. Babulkar sir. Thank you to Dr. Gaurish Palekar sir, Dr. Gautam Kodikar sir, Dr. Subodh Mehta sir, Dr. Amit Agarwal sir, and Dr. KJ Reddy sir. Very good moderators. And I'm thankful from Regrow and thankful to the Ortho TV also.
Thank you. Thank you for the Regrow and Ortho TV. We'll meet again. Nice to see
Yes.
Thank you,
all
KG.
of you.
Thank you, sir.
Thank you. Thank you, sir.
Gaurish,
Take
nice
care.
to-
Bye-bye.
Thank you.
Have a
Thank
good
you,
night.
Yeah.
Nice.
Thank you. Thank you, sir.
everybody.
Thank you.